Hi, everyone. My name is Mari Silbey. I'm Senior Director for Partnerships and Outreach at US Ignite, and I'm pleased to moderate today's panel discussion on telehealth and connected communities. For those of you who don't know us, US Ignite is a high-tech nonprofit focused on expanding broadband connectivity, smart city initiatives, and also the frontiers of wireless network research. Today, joining me are three panelists: Dr. Bob Corona, CEO of Upstate University Hospital and a member of Syracuse's Smart Gigabit Community Advisory Board. Welcome, Dr. Corona.
Thank you very much. Glad to be here.
Dr. Sudheer Dharankota, and please correct my pronunciation, the Managing Director of Duke Tech Solutions and Chair at SCTE, the Cable Standards Organization, particularly the Aging in Place and Telehealth Working Groups. Welcome.
Thank you for having me.
And finally, Bill Maguire, founder of the Connected Communities LLC Consulting Group and author of the recently released white paper titled Advancing Health and Wellness via the Smart Home. Welcome, Bill.
Thank you very much, Mari.
Excellent. Well, to get the conversation started, we know that telehealth is obviously a very large and complex topic, and it goes without saying that we will not be able to touch on all of the facets of that topic during today's discussion. But our focus will be really on the relationship between connected healthcare applications and smart city initiatives. So given the white paper that was just mentioned, the Advancing Health and Wellness via the Smart Home, we're going to reference that and keep in mind the unique perspectives and expertise of our panelists to explore apparent changes to the concept of telehealth, particularly in the wake of the COVID-19 pandemic, and then also consider potential opportunities for state and local governments and their smart community partners to leverage home-centered healthcare applications to advance health and wellness in their communities. So on that note, I'd like to kick off our discussion with this question for our panelists. What is your definition of telehealth, and how has that changed? How has telehealth changed as the way you see it in the wake of the pandemic? And Bob, do you want to take a start?
Sure. So I go way back, as I mentioned to you earlier, into telemedicine, where there were a lot of proprietary technologies that were used to do communication. So I kind of define it as any technology used that is in the communications or computing world that facilitates the service of providing healthcare. And I think it's kind of interesting that now all of a sudden with the pandemic, it's been accelerated that people are using consumer off-the-shelf technologies more frequently to allow us to do telehealth. And it really helped us a ton when we were in the midst of the pandemic, just taking the use of iPads and cell phones and all kinds of other off-the-shelf stuff and kind of pulling it all together and making it work. So I have a pretty broad definition of it. And it's really helped our hospital, which I call a hospital without walls, reach out into the community.
And I want to stay with you just for a minute before I let somebody else jump in, because you're also part of a smart community advisory group in the Syracuse area. How did you end up getting involved with the group, and how do you see healthcare as being relevant to those discussions?
Well, I've been in the Syracuse community quite a while. You know, I left academia and worked 16 years in industry, but the industry I worked in, the company was close by to Syracuse. And when I came back to the academic medical center, I was kind of known entity with the business community and the academic space. And I had done a lot of innovation. I helped with the biotech accelerator launch, and we did a lot of work together with the community. So I think that just because I happened to be around and available, they asked me to be on the advisory board. But I have a passion for this stuff, and I'm pushing to make our hospital a smart, sustainable hospital by the use of technology. And this is very critical to the success.
Let's talk a little bit about how telehealth has changed, and we'll kind of look at the short view lens and then take a bit of a broader look. But Bill, I know you had a stat in particular about telehealth before, and specifically virtual healthcare visits before the pandemic started and since the pandemic started. And Bob, you mentioned that as well. But Bill, do you want to talk about the stat that you've talked about a couple of times?
Sure. I mean, it was a very interesting time to do some research on this space because, as Dr. Corona references, the changes were happening in real time. And I was really particularly interested in looking at Medicaid statistics because, of course, Medicaid programs are run by state governments, and oftentimes local governments are aiding in those efforts as well. So, if we rewind the clock to March of 2021, March of 2020, there were about 11,000 patients or that were accessing healthcare services via something that I think Dr. Corona would recognize as telehealth.
Is that nationally?
Yes, that's right. According to the statistics I've seen, by the time we get to late April of 2020, that goes from 11,000 in March to 1.3 million. So about a 10,000% increase in a 6-week period. So what was once kind of a theoretical question about the feasibility of providing healthcare services to people in their homes was really proven out in a very large scale experiment, one that I think Dr. Corona and other medical professionals would have had a hard time imagining before the pandemic hit. But it showed quite readily, A, how dynamic this space was, and then B, some of the early indications of what the impact might be of these services being available at scale.
So I want to get into that briefly. And Sudheer, I promise we'll get to you in just a moment. But since you would have been on the front lines during the pandemic, Bob, I'm curious to know what you saw telehealth as enabling specifically during this particular health crisis that wouldn't have been possible before.
Well, you can imagine there were a significant number of patients that were afraid to come to the hospital because they thought they would get COVID. So I mentioned that mainly our ambulatory provider-based clinics exploded with telehealth visits. Especially, it seemed like neurology was a big area, but many of the other areas. Our emergency medicine people created a telehealth triage, and we also did a lot of inpatient work with telehealth because with the COVID patients requiring so much PPE use for donning and doffing in and out of the rooms, we put iPads in all of the rooms, and it allowed the patients to communicate directly with the nurses and then often with the doctors. And it actually improved the patient satisfaction because they had so much more access. So that was instantaneous. The other thing is the people that did have COVID-like symptoms or influenza-like illness symptoms that were overwhelming our emergency department. We were commissioned to have the emergency rooms have 15% buffer, and our capacity to have 15% buffer. So we had to be really careful about balancing our capacity. And so what we did is we created an influenza-like illness clinic. And that clinic would make sure that the COVID patients that were stable enough to go home would go home with what I would call telemedicine technology, a simple oximeter, a thermometer, maybe potentially a home blood pressure system. And it would connect in every day, and we would monitor through video teleconferencing the patients that had COVID, but they were being managed in their home. And it really decompressed our emergency department pretty well. So it really helped us survive. And then from a financial point of view, if we didn't have all of those visits in our ambulatory center via telehealth, we would have got hammered worse than we got hammered. So it offset a lot of the financial loss. We all still lost money. I think most of the hospitals did. We did get some help from the government, but it wasn't quite enough to offset all of our losses.
Oh, that's interesting. I certainly would have thought of the resourcing component and the being able to improve care for patients and even customer satisfaction, or patient satisfaction, which is excellent. I would not necessarily have thought of the financial impact in the short term based on the services you were able to continue providing. Let's zoom out a little bit, Sudheer, and take a look at, so we saw things change very rapidly from a perspective of the coronavirus hitting and everybody having to adjust very quickly. What about from a longer term perspective in terms of how you see the environment as having changed or evolved that might put us in a better place now to actually activate some of these telehealth initiatives?
That's a very interesting question. Actually, let me reminisce a little bit. So I come from the telecom industry. I'm a technologist, right? So for us, video and audio communication is everyday, day-to-day activities that we've been doing forever. If you very narrowly define what telehealth is, it's a basic video communication. So we actually did, coming out of Alcatel-Lucent, we came up with the telemedicine product in less than a week, a prototype. In 2009, so integrating the devices, integrating some of the medical devices like otoscope and blood pressure meters, which they have USB ports, you can easily connect it. It doesn't take much. The real issue there was the adoption. And in 2009, forget about in the third world countries where we were targeting specifically at the time we were developing in India. Even in US, nobody wanted to fund our concept. Going out of UPMC, we were also working with the UPMC on a different project. We realized that this is a very important project which really assists a lot of people. So we could not get the traction. We started the telehealth program in SCTE in 2019, just before pandemic hit.
And SCTE, for those who don't know, is the Society for Communications, Cable Telecommunications Engineers.
Right, it's a standards body for the telecom operators, right? Cable operators. And we started off, there was lackluster movement in there, but within a year, you can see the amount of excitement there. Like Bill was talking about, the cases have gone up and the adoption has gone up. You have seen cable industry actively working with some of the healthcare providers. If you look at Cox, Acquire, Tropolo, like that, right? All of them crossed the technology chasm, and also they are trying to get into the healthcare industry. But one thing I want to emphasize, what Bob also talked about, is really the adoption, right? So now it's going in scale. So what for in the future, right? So if you, and I was on a panel yesterday with the user group, those are 65 plus. How do I use the technology, right? So that's a very basic question. I understand these things. How do I make this operationalized? Now, going beyond, how do you collect the data? How do you analyze? And basic remote monitoring, like Bob was talking about, is one piece. Then what do I do with that is the next piece. How do I go from a basic video communication to a collaboration environment? So how do I make it doctors, patients, and also the family members be part of it? So that's a very exciting world right now, which actually pandemic opened for us for the innovations.
Right. Yeah. So you brought up the idea of the cable industry and the cable industry getting involved in telehealth, which is probably for most people doesn't sound like a match that they are used to thinking about. Those tend to be two very different sectors that are now potentially coming together because of technology. I guess before we jump into that, because I think there's going to be a lot of different sectors that are trying to overlap with each other, particularly as connectivity becomes relevant everywhere. But so I guess a little bit before we jump to that and where the cable industry sits, I'd love to talk a little bit more about if we've seen the environment improve over decades, and if albeit slowly, and then we've seen this massive ramp up and demand and an interest since the pandemic. what are ways that you all can see that some of the benefits that were recognized during the pandemic could start to be realized in a post-pandemic world? So what are the benefits that we as consumers, as patients, should start to be looking for, or that healthcare providers should be seeking to provide, that put into effect some of the lessons learned over the last 15 months? And Bob, you're probably best placed to start that discussion.
So, I was thinking back as you were framing up that question to Jay Sanders, who was considered like the father of telemedicine way, way, way back. And when I started the telemedicine program at Upstate in the mid-90s, he came up to visit me. And I remember him telling me about, I think it was his grandmother, when the first telephone came into the apartment building she was in, everybody had to leave their apartment to go down to the lobby to use the one telephone. And that's not when telephones took off. It's when telephones got into everybody's apartment did they take off. And I think it's kind of the same thing now, that people were forced to use some of the technology. Now that they've used it, just like Zoom, who would have thought these video conferencing systems would have taken over our lives? But a lot of people don't want to go back, even though now in New York State, we can go back to live meetings in many places. They like the convenience of Zoom. And so the patients also like the convenience of not having to travel to the big city, find a parking spot, go through security, sit in a waiting room and see a physician or a nurse or whoever they have to see. They love the idea of being able to log on, talking. And, we teach our medical students that you can make the diagnosis 80% of the time through the history. So you can get a good history over a telecommunications connection. And then if you do need a physical exam, you bring them in, or you have to send them off to get an imaging study or lab work. It really makes it a heck of a lot more convenient and a better patient experience. So I think this is going to stick. We see a lot of patients that say, hey, can I do a virtual visit? Can I do a telemedical visit? The one thing that seems to kill the use of the technology is if it disrupts the flow of the normal patient-physician-nurse relationship. If they have to log out of their EMR and log on to a proprietary telemedicine system, a lot of the docs and the nurses do not want to use it. But if it integrates right into the medical record, they're into the medical record. I think it was mentioned that how important it is to grab the data and then what do I do with it? If it's just all part of the flow, our providers love it.
So
but
that's,
if you have to disrupt the flow, they don't like it.
That's great. So that brings up a good point. We've started out talking about the benefits. Let's talk a little bit about the challenges, and let's start with the technology, or sort of the operational challenges. What are the things that we still have to solve before we see widespread adoption at both the healthcare industry level and the patient level? Bill, do you want to maybe start there? I know you've examined this quite closely.
Yeah, I think Sudheer will be in a good position to talk about how we get to scaled deployment. But I guess maybe just to challenge the premise a little bit, I think we saw at scale deployment over the last 12 months. And the technology was not perfect, but in terms of like demonstrating kind of the smart home and available tools as a viable platform through which patients, their providers, their loved ones, and even payers all seem to see some benefit and identify the value. That speaks to me to be providing something of the bedrock for a lot of the work that'll need to go forward. So maybe I would defer to you a little bit on kind of that roadmap on where we go from here. But I am well disposed to believe that the case has been made to whatever degree that we saw something kind of extraordinary over the last 12 months.
Yeah.
So what do we still have to solve, Sudheer?
Yeah. How do you turn an Alexa Echo, Alexa show into a sustainable service? In a nutshell, that's what it is. Everybody thinks that I have an iPad and I have a video option on this. My Alexa is talking here. But then how do you turn that into, like Bob was talking about, a service that providers can use? Make it into an adoptable service that an elders and the end users can use. How can you provide value? Like, how do you reduce the cost? How do you, if there is a problem, how do I make sure that turns into a quick, that gets resolved quickly? And some of the folks that I talk to, my doctor colleagues and partners, they say that we have all these platforms now. We are becoming IT folks in helping people resolving it. So these are really the the symptoms of a problem where, yes, we are excited about the telehealth service, but then how do you make that as a sustainable service is the challenge, right? So that's a basic premise that we are getting into. So there are 300 plus companies that are out there. Everybody is throwing gadgets like Bob was talking about. How many do I need to, if I go to a specialist, do I need to use their telemedicine platform? Or if I go to my primary care physician, do I use a different platform? So all of these problems will become very apparent when you start using that at scale, right? So that is where we are heading right now.
Yeah, so it's funny. I was in another conversation recently where we were talking about the fact that, we hit the point where every company is a technology company. And now we're getting to a point where every company or sector even has to be a connectivity sector or connectivity expert, and also a platform expert. So if that's the case, but we also recognize that healthcare institutions aren't well placed to be experts in that. We want them focused really on their primary focus, which is healthcare. Then what are the other players that could come in that could serve that role, and how kind of let's give weight to some of the different possibilities. Who is best placed, and what are some of the advantages for who might come in and be a platform provider to help both sides of the equation?
Well, I can tell you our experience. It's really the best of breed kind of rises to the top. There have been several different video conferencing platforms that were introduced early in the pandemic, right, to do all of our meetings. And look what we're meeting on today. That kind of evolved at our institution, that everybody liked this platform the best. Mm-hmm. And the medical students, for instance, when I teach a class in clinical bioethics, and we've been doing it remotely, we started out with two different other video conferencing technologies, and the students voted that, hey, this one's the best one. This is the one we want to use. And it also got to the point where, in the early part of the pandemic, when we were struggling with how to manage the very acutely ill COVID patients, we ended up using our telemedical technology to link in with the physicians in Wuhan to talk to them about how they were managing patients, because they were managing them early on. And they were the ones that were telling us, do use this drug, don't use this drug. These kind of x-rays are misleading. This imaging could help you. This is the way you position the patient. And all of a sudden, through a couple of weekends of talking with the docs in China, we improved the outcomes of our patients. So it was, the telemedicine doctor to doctor that was extraordinarily helpful for the patients. So I think that these various technologies, we partnered with Microsoft to do a chat bot to answer questions, because everybody in the community was calling us on what to do. They helped us create these chat bots. They also helped us create these question and answer systems for the people entering our hospital, to create a barcode so that they could get a pass through. And then we didn't have to spend the $25,000 a week in labor to have somebody at the front desk handing out a mask and asking these questions. Microsoft did all that stuff for us, which was really great. And there were other companies that got involved. So we just found that the kind of the best of breed raises to the top, and the people started using them, and they've continued to use them.
Now, what about, where does, Bill, I want to get your take on this. Where does the community, be it the local or state government, where does that entity fit in as we look at the healthcare provider, potential technology providers, whether it's gadget providers, whether it's a data platform, whether it's the connectivity piece? How does the government fit in? Because I know you and I have talked about the government as a payer, but can you walk us through that a little bit?
Sure. So it really was the focus of my research into this telehealth space, to think about how telehealth may or may not be, or should not be, considered a smart city application in the way a lot of the US Ignite community might understand a smart city application, which is to say there's a plan where lots of different stakeholders come together. There's an assessment of sort of the technology needs and the assets the community might have, and identification of partners, and then some goals associated with a project, particularly community-wide goals that are looking to advance sort of sustainability and accessibility of services and standard of living in that community. And it'll come as no surprise to you, Mari, as an expert in this space, that telehealth really checks a lot of those same boxes that we see when we're looking at smart city applications that mitigate traffic or measure and attempt to improve air quality or help a community prepare for disaster and emergency recovery. So I started to think to myself, the health and wellness of our communities are certainly an objective for state and local government leaders. They've probably felt up to this point that they didn't have a lot of leverage or a platform on which they could advance those. And my recommendation, and based on my research, is that the experience that we see over these last 12 months really should highlight for state and local government leaders an opportunity to convene, to potentially fund, now that we have the American Rescue Plan and billions of dollars coming into states and localities, potentially fund some pilots, and really play an active role in making sure that telehealth, seen as a smart community application, has the objectives that the community might have in mind, as it relates to providing services for those who need it the most or who have been underserved previously. So I'm not sure if that's exactly where you were headed, Mari, but that's certainly one of the key recommendations that I put forth in the research paper.
No, I think that's good. And I think that actually brings up another point, which is when you're talking about governments and governance, there are regulatory issues. We've talked a little bit about the technology. We've talked a little bit about the economics of it, although not in great detail. But what about from a regulatory perspective? Are we ready today? Are there still regulatory challenges to implementing some of the ways in which we think telehealth will be most valuable? Sudheer, go ahead. You want to answer this one.
I'm not a policy expert, but I can tell you one of the major challenges coming from the cable industry looking into healthcare, HIPAA is pretty scary for the folks. If you look at the problem, telehealth problem, it's easily solvable. There are multiple solutions that are already existing in the telecom industry to solve the problems: the collaboration, the communication, the service aspects, the billing aspects, the connectivity aspect. These are all the problems the telecom industry already solved. Then why are they not all over the place in the healthcare problem? And so the one question, the deterring factor, is people are scared to touch healthcare. Right? So that starts off with HIPAA compliance, and then state to state differences in the policies. Right. And then obviously if you look from the doctor's point of view, it's the reimbursement, right? So all of those, these are the major roadblocks that the industry has, or the inter-industry collaboration has, which sort of got resolved due to a pandemic last year, and hopefully many of these can continue. The resolutions can continue beyond pandemic timeframe. Right?
So you actually brought up a number of things there from the perspective of how you deliver telehealth, including, not just the technology, but also how do you bill for it? How do you support it? And then where you got into on the regulatory side was specifically around reimbursement. Is what would have to change at this point to make providers of all kinds less nervous about touching, healthcare, given the potential liability concerns, given the patient privacy concerns? What would have to change to open some of those gates and make telehealth more scalable, more possible, and more valuable?
I'll let Bob answer it, and I certainly have some opinions on some of the.
Well, I think sometimes the regulations are confusing and they're state to state. And I think that as we become more comfortable using the technology and the regulators become more comfortable with the technology itself, I think it will improve. People are really worried, like, for instance, when anything new, like when we started out with the vaccines, if you look at that, there were many physicians that were afraid to obtain the vaccine and give the vaccine because you had to give it in a certain number of days. And there were threats of fines if you inadvertently gave a dose 1 to somebody who needed a dose 2 and all that. And that was a byproduct, I think, of the preciousness and the limited supply of the vaccine. But as the vaccine became more available, then the regulators kind of loosened up on it. And they didn't have as much fear about, black market stuff. And people started to become more comfortable with using the vaccines and taking them in their offices. I think it's just a matter of people seeing other people using it, being comfortable with it, the insurers coming out and saying, hey, we're committed to keeping the reimbursement where it is now, and the regulators saying, hey, we're open to being more contemporary in our thinking with the policies and the regulations that govern telemedicine. That most of the telemedicine programs of the past were byproducts of grants. And then when the grants ran out, the telemedicine program failed. And the other thing I can't emphasize enough is if telemedicine is considered a one-off, or what one of my friends, I used to say, stunt science, then it doesn't last. But if it's integrated into the electronic patient record, and remember how long it took that to be adopted. I mean, we actually had to pay physicians to implement an EMR into their practice, and now many wouldn't do without it, or can't imagine doing without it. I mean, if you ask medical students, they don't know any other way. It was funny. I was talking to medical students in one of the classes I was teaching about how important voice recognition is, and it is important, and a lot of doctors use it. But the medical students of today have been so used to texting and typing, and they can type and text faster than we can talk. They don't see voice recognition as that
Interesting. Interesting. What about when your hands are tied up? I mean, I would think medical experts in particular would, occasionally have their hands tied up. That's interesting.
Occasionally, but documentation, usually your hands are free.
Right.
And a lot of stuff is very cognitive now, not necessarily, use of your hands.
Interesting. Sudheer, you said you had many opinions on this. Do you want to weigh in as well?
I will. So, in my opinion, the scare that we created in the telecom industry to touch healthcare industry is unwarranted. That's a very radical statement, but if you really look at it, we have PII information. So HIPAA thinks that, okay, the patient's privacy is very important, and
PII being personally identifiable information.
Identifiable information. In the telecom industry, we have similar constraints, right? So we have been deploying it. We have learned to live, or we have learned to build the products around it. We have strongest security protocols that are developed. So we develop, and like this platform that we are using, we developed unified communications and integrating, communicating, and also integrating the devices. This is all second nature to us. How many IoT devices have we integrated into our platform? These are all gadgets, like you said, Mari. These gadgets, we are good at integrating the gadgets and using the information behind the scenes. If you look at the telemetry information that we gather and use it to identify the root cause for problem analysis, is something that infrastructure is being built, refined, and optimized for telecommunication industry. What is preventing us from extending the same for a very specific vertical, which is healthcare, right? It's really our concern that healthcare industry is very restrictive. And if we get away from that, and if the policymakers, if the government agencies can relax it a bit, or make sure that we are not penalized heavily while we are building these initial prototypes, it will take off, right? We will be helping Bob in less than a month. I can guarantee with a standardized solutions.
That's interesting. So we had, you on the one hand are saying we know how to integrate gadgets with platforms, and Bob, you on the other hand are saying we need to integrate specifically with the EMR systems, the electronic medical health and records systems. So that seems like a pretty natural integration point at this point, if we're going to bring what telecom and connectivity and the technology and gadget world and healthcare all need, if we're going to bring those things together. Bill, I want to let you weigh in a little bit too, because again, trying to figure out where the government steps in here, again, state, local, federal, however you want to look at it. Somebody here mentioned the part about, I think it was Bob mentioned the part about grants that run out, or the idea of doing stunt science, and therefore it's not embedded into normal processes, and it just kind of runs its course and then ends. Where's a good place for, connected communities as we think about them? Nobody wants to be a dumb city or a dumb community anymore. Everybody wants to be smart. So where's the starting place as communities are thinking about healthcare and telehealth?
Yeah, Bob's point resonated with me as well, the stunt science comment, because I think in the early days of the so-called smart city movement, a lot of us will remember this feeling that they were little science experiments, and that really what we needed to get scale was to be integrated into the actual workings of the organizations, of the municipalities, of the counties, of the states. And having a real impact on people's lives. Of course, we needed those initial pilots to show feasibility, show viability, show impact. We may have had that period over these 12 months of extraordinary times where we've, I would argue, shown feasibility, viability, and impact. But there is going to be, I think, a large role, there's no doubt, at the very least in a regulatory framework for state and local and federal governments. There was a number of emergency actions that were taken by government leaders. Dr. Krohn also mentions some of those actions were taken by insurance companies as well, to recognize that we were in unprecedented times. There's bipartisan support in Congress for laws that would make a lot of those emergency changes permanent. There's a lot of support for those changes among key stakeholders within the medical ecosystem. This is an area where state leaders can show their commitment to having telehealth be a part of advancing wellness and health in their communities. They can distinguish themselves. They can work with experts to identify the kind of regulatory framework that would be most supportive of pilots, these sorts of things. So I think in addition to convening, in addition to maybe using some of the funding, there is also an opportunity for leadership in the regulatory space. I think we mentioned a lot of them, but just to kind of identify them, it seems to me from my research that the regulatory space kind of comes down to coverage and payments, professional licensure, online prescribing, and then privacy and security. That might not capture everything, but those 4 buckets seem to be where a lot of experts identify. And state governments have a large role in all 4 of those areas.
Okay. Sorry, go
Marty,
ahead.
if I can
Please
add a couple of points. Right. I want to see this from the solution point of view. Right. So if you look at the VA, Veterans Affairs, right, they are highly experienced in offering telehealth services. So their main goal is obviously to assist the veterans, but they want to reduce the travel time for the veterans and drive adoption or drive the service closer to the veteran. So what they came up with is the satellite offices where it's manned and they have devices. And there is a significant adoption for that one. The communities can be built with the similar concept. Right? So if you look at, we are looking at, I have a friend who's a builder. He wants to build an elderly community where he wants to have a small telemedicine office. There,
Interesting,
right?
right.
A manned facility. So if you very targetedly approach the problem, anybody above 65 who cannot really commute, who are not very tech savvy, and they do want a human interaction, you can have that satellite facilities run by local government or the cities, and you can provide, use the telehealth platform to provide the services. Right. So
yeah,
I mean that is one quick win for everybody. In the SCTE, we're also trying to introduce a concept. Although we are starting off as an individual family, but we want to expand it to a community level also. It's called a telecom closet. We started off calling it as a healthcare closet concept. It's how am I going to build future buildings or facilities with a modular healthcare services in mind, device integration or EMR or video communication platforms, right? So like that, right? So those kind of things are easy win and a quick adoption for people who wants to, for the cities who wants to really introduce the telehealth services. Right.
So it's very clear, and everybody's sort of said this over and over again, that we've proven the value over the last year plus during the pandemic. What are some of the other areas, if we had, for example, these telehealth closets, if we had these hub facilities, what are some of the benefits that we could see from a healthcare and from a patient outcome perspective? One of the things that I certainly think about, and that some of us I think have talked about too, is the management of chronic disease. What are the, we talk about quick wins. What are the quick wins from a both health outcomes and potentially cost perspective? Because we are talking about people having to fund these initiatives.
So we have a Joslin Diabetes Center at Upstate that serves a significant portion of the state of New York. And patients have to come from a pretty significant distance. And the head of our Joslin Center has been doing telehealth visits for, I bet you, 25 years. And it's extremely helpful, especially for diseases like chronic diseases like diabetes and people that have metabolic syndrome with associated hypertension and obesity, people with osteoarthritis, all the chronic diseases. I think telehealth is the way to go. And we've seen us, if there's one area that it's been stable in, even pre-pandemic, I would say it's some of the chronic disease management.
Interesting. So where is there room for that to grow? And I know we're short on time already. The time has passed very quickly, but where is there room for that to grow? And what innovations might we consider in the near term? If we could define our own next pilot or next thing for a community to try, or a healthcare system to try, or a technology provider to come in and try that would deliver significant benefit to our communities, what might that look like?
Let me take a shot at it, right? So if I think of a pilot, what would be the script for the pilot? So for me, there are three things, right? So it's really, what are we solving? And how do we increase the adoption? How do you make it scale? Right? So what are we solving? There are a lot of problems that are out there that could be addressed by telehealth. So I would suggest focus, well, if there is a best in class prototype that I want to develop, my toughest customer base is 65 plus. I take them, I take a chronic condition, they cannot drive, or probably 70 plus, they cannot drive, they need help. How do I solve their problem? That's the thing that I want to go after. Now, for them, the challenge is really adoption. How do I make sure they adopt to the technology, right? So if I target that market, and my main problem is technology is not a problem for me. Technology is there. It's really tuning that to the use case, right? And then the third thing is really showcasing the benefit, which keeping the theme of the discussion today. How do I show the benefit of telemedicine, which Bob is already talking about, the travel time, the problems that you're going to have by missing your appointment, the cost reduction, all of them is a concept of a satellite facility, right? So you put it in a location, manned or unmanned. How do I operate that kind of a scenario to solve the telehealth problem? Will increase their option. I'm just copying everything from what VA does, right? So literally, that's what it is, replicated in large scale.
You know, I think telemedicine dramatically reduced our no-show appointments because of the convenience that you mentioned. But, you know, I'm pushing our institution to be a hospital without being defined by the walls. So the physical structure should not define the services that our hospital provides. And so, you know, if you look 30 years ago, people that are presently in our intensive care unit probably would not have survived. People that are on our med surg floor now probably were in the intensive care unit. And people that are coming into even lower acuity settings, or people that are on our floors right now could probably be managed in their homes. And so pushing things continually, disruptively out of the hospital, out of the acute care settings, into settings, I think, that are just better healing environments. This is where technology can really help. You know, when we had to tell patients that they couldn't have their families visit, and we had to tell families that they couldn't visit their loved ones, and their loved ones passed away without families present, those kind of emotional triggers are going to force us to rethink institutions that provide healthcare, and people are going to want to be cared for in their homes or in settings where families can be together. So, you know, I was told that the ATM was thought of when some guy was standing in the bank and said, "Why do I have to wait in line to get my own money?"
That's a good point.
So people are going to say, "Why do I have to be cared for, you know, in a hospital? I'd rather be cared for in my home or some lesser acute setting."
Well, I'm going to let you have the last word, Bill, since you looked at the home quite a bit in terms of being the space that is connected, the space that is served with connectivity, and that could be the best healthcare site for a number of patients. Any thoughts what you want to give here?
Well, thank you for that. I mean, I think your question about easy wins, again, I think we've seen the easy wins. The white paper that we've referenced a number of times includes a lot of peer-reviewed journals that have looked very carefully at the data associated with the sort of grant-funded pilots that Dr. Corona referenced. And so there really are, I think, a well-established impacts, healthcare impacts, cost effectiveness that we can point to. But I think what we could pull out of the best practices of smart community planning is, instead of thinking of easy wins, think of meaningful wins. So let's engage or an invitation to state and local and county government leaders to engage their community, identify which of those populations would benefit most from a pilot that would leverage home-centric healthcare. Which communities, where is the county or the state spending a lot of those funds? How can those funds be spent most effectively? Where is there a gap in services, and how can that gap be filled? I think that's an ideal role for local and state government leaders who might kind of take this opportunity to dive into an area, because I think all of us as panelists recognize this is a very complex area. It's an area where everyone feels they need to tread lightly, but it's also an area that's very, very meaningful to our kind of standard of living. And, so it should be an area where state and local governments feel as though they have the mandate to act.
And I think that's a good place to leave it, looking not just for quick wins, but for meaningful wins. There is a lot to be gained here, a lot of value to bring to the healthcare system as a whole. And one of the next steps is going to be figuring out the partners and who all can help deliver that. But it certainly feels like we are in the right space to be making some serious moves forward. So on that note, I want to thank all of our panelists, Bill, Bob, Sudheer. Thank you so much for joining us today. And we look forward to continuing the discussion in the future.
Thank you, Mari.
Thank you, Mari.